Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are excited to be sitting down and speaking with Dr. Enid Martinez on critical care nutrition. Dr. Martinez, please tell us something about yourself, including your professional background, but also something you enjoy outside of medicine.
Wonderful. Thank you, first of all, for the invitation and the opportunity to be a part of this podcast. So something about myself, I am from Puerto Rico, born and raised. And Alice, I actually moved from Puerto Rico to New York to go to medical school at NYU. And I did my pediatric rotation as a medical student over in Long Island. So maybe we have some other more things in common that we thought. So medical school in New York, and then I moved to Boston for pediatric residency at the Boston Combined Residency Program, which runs between Boston Children's Hospital and Boston Medical Center, and chose to go into critical care medicine. So I completed my fellowship here at Boston Children's Hospital as well, and have stayed as a faculty member for now over 10 years. What do I like to do outside of work? I really love cooking, but it's because I like to follow the recipes. And if you give me the time to follow a really nice long recipe, so something that I get to enjoy the process, I will have lots of fun and hopefully good food at the end, although that is not always the product, but I definitely try. So that's a little something about myself.
That's fun. I like the stipulation because everybody cooks differently, and that is a very specific way. You're like, I will get it perfect, like it's a lab, right?
That is spot on, like it's a lab. I'm about following the recipe and getting the ingredients they recommend. And if somebody has even commented modifications, I look at what they said. So that requires the time to chop patiently and have a nice podcast or like music in the background. It's definitely about the process more than even the eating, although we definitely get to enjoy it in the end.
You have an interest in nutrition and related research. Will you tell us more about that?
Yes. So I actually have a basic science research background in terms of what I did in undergrad and medical school, and then did some retrospective chart reviews as a resident. And when I started fellowship, I was looking to expand my clinical research experience and was not sure what to focus on, like many of us who go into fellowship and are thinking about what to do. And I bumped into nutrition and I loved it. And what I loved about nutrition is that it applied to all patients. I obviously was interested in certain aspects of studying sepsis or respiratory failure, but that applied to the patients who had sepsis or respiratory failure. And yet nutrition is relevant to all of our critically ill patients. And so I started working with Nilesh Mehta, which is, I think, the father of critical care nutrition in the pediatric world. Had the opportunity of doing studies with him, both interventional studies as well as chart review studies, and learned many of the different facets of nutrition working with him and fell in love with it to the extent of continuing to do it myself as I went on to become a faculty myself.
Well, that's wonderful. And we appreciate it's almost the reason why we wanted to make sure we had a nutrition episode. It's such a way to improve the quality of your care. And we're excited to have you here to really dig in how to do that. Before we get started, do you have any conflicts of interest to disclose?
I do not have any financial conflicts. I have an NIH grant to do clinical translational research on gastrointestinal function in critical illness. But that means I will be very excited about this topic and may mention something here and there about the work that we're doing. But otherwise, I do not have any disclosures.
That's excellent. Alice, if you don't mind, I'll give us our first question this time. So I'm reluctant to share that sometimes nutrition is kind of put down by the wayside on ICU rounds. Like we generally talk about the ventilator and hemodynamic support, et cetera, et cetera. Then we get to nutrition. And sometimes the questions are dichotomized, like yes or no, or more or less. To get things started, do you mind just sharing, why is nutrition in the critically ill child so important for us to discuss? How does this impact outcomes?
So as you mentioned, the first thing is to address our ABCs. But at some point, those are addressed and the patient is ready to start receiving nutrition. And it is critical because it is part of their recovery. As we talk today, I'm sure we'll address certain aspects of how every single critically ill patient is impacted in one way or another by a nutritional issue. Maybe they can't PO. Maybe they're having postoperative nausea and vomiting. Maybe they have an ileus. They're malnourished. They have altered metabolism. And so there are many things that need to be considered first as what is potentially limiting this child's nutrition and how to address it so that we can help their recovery, help them rehab, help them get off that ventilator, right? And breathe on their own. And all of that, yes, it's how we think about our sedation and our ventilator and weaning, but it's also about how we help that patient's body recover from this very stressful hit. So it is relevant to every patient, and it is very key once we've gotten over those ABCs to think early about how am I going to help this patient's recovery and the role nutrition has in that.
How do we do at this as a field? Is malnutrition common in critically ill patients?
Malnutrition is reported to be present in about 20% of pediatric critically ill children. What's interesting about that statistic is that it was first reported in about 1982 by Murray Pollock, and it remains the same for ICUs like those that we see in the United States. So I think that gets more to the pathology and the conditions that many of the patients that we take care of have and how that influences malnutrition defined by undernutrition. However, if you expand that definition and you include being obese, which is often associated with vitamin and micronutrient deficiencies, that percentage is larger and can be as high as 20% of pediatric critically ill patients are obese and will have nutritional challenges associated with that. So now we're at 40%, and that is a percentage that has grown and changed over time. And the other thing that is even more important is not necessarily that population that's coming in malnourished that's part of the pathologies that we tend to see in the unit, but the fact that at least in one study, it was shown that up to 50% of patients admitted to a critical care unit will develop malnutrition under our care. And I think that's where things are most modifiable, when they're under our care and we can help prevent the development of malnutrition.
Now, that's fascinating. So you've already overviewed for us that a large proportion of kids coming into the ICU are malnourished. And then there's a high likelihood that this patient, if they're critically ill, could become even more malnourished. So to kind of lean into that more, will you tell us more about how critical illness affects the metabolism and maybe can contribute to this?
Critical illness impacts metabolism immensely and very differently from how we learned about metabolism and starvation and malnutrition. So these things are linked and they obviously play off of each other. But even if you're not malnourished, when you come into a critical care unit with sepsis, trauma, surgery, your metabolism is going to be severely altered. And it's going to basically activate all those catabolic pathways. You are going to go down the glycolysis pathway and gluconeogenesis. You are going to turn those triglycerides into fatty acids and down the ketone pathway. And then you're going to break down protein to actually generate amino acids to go down gluconeogenesis. The things that are important to mention, though, is that those three pathways end up having some maladaptive, inefficient ways in which they work. So one is, despite going down glycolysis and gluconeogenesis, there is insulin resistance. So you have inefficient glucose utilization, hence the fact that we see a lot of hyperglycemia. So the most efficient pathway that we know of to make ATP for this body that's on hyperdrive in the setting of critical illness ends up being not as efficient as it can be. We know that ketones definitely can play a big role, but usually are not the primary form of trying to generate the energy that we need. And so you end up almost using your protein as your nearly primary pathway. And although that can hit the target of generating ATP and also peptides needed for wound healing for your immune system, that can be quite maladaptive in that you're losing the same muscles that you need to recover, that you need to be able to get off that ventilator and have strong diaphragmatic muscle and intercostal muscles to be able to breathe. And so metabolism is extremely altered. And in addition to that, the way that it's altered, it's somewhat maladaptive, which is why patients who become critically ill often have a big hurdle on the other side of their recovery. If I could add one more thing, one would say, well, then maybe if you just give tons of nutrition, you can overcome this. And the reality is that there's no amounts of nutrition that is going to reverse that metabolic state. What is going to do that is stopping the insult and the trigger. It's source control for infection. It's, getting over wound healing for surgery. And that is why the prime example of the hypermetabolic state that can happen in critical illness is what happens to the patient who has burns, because that is a patient population that their recovery time to not have that hypermetabolic trigger can take months to almost, it's been estimated in some instances, up to 2 years.
Wow.
Yes. So that is the key thing. You can feed someone very efficiently, but you really want that underlying stressor to come under control. The other piece to keep in mind, however, is that it used to be thought that all of our patients would be in this hypermetabolic catabolic state for a very long time. And I think that with many advances, from diagnostic advances, antibiotics, sedation, synchrony with our ventilators, we have found that the period of time in which patients are hypermetabolic is much shorter. It can be in the range of just days to most a week. That means that we need to be careful to then not overdo things when we talk about nutrition in these patients. So they go through this state that is altering everything, but it's a bit short-lived, except for that burn patient population that I mentioned, which is still known to be hypermetabolic for a very long time.
No, that's fascinating. It's almost like there's an aspect of metabolic failure that comes along with critical illness. In the same way that a child might have respiratory failure or shock and cardiac failure, it seems like there's also this aspect of metabolic failure that we have to stop the offending agents and help this child recover. Do you see it the same way or similarly?
I love that. I don't think I have ever heard someone refer to it that way, but you are correct. There is a metabolic failure that's going on the same way that we're seeing all these other organs fail in someone who is critically ill. And the recovery isn't as simple as a Band-Aid or a patch. We know there's a long process that can take to get over respiratory failure and cardiovascular failure. And it's the same thing with what happens with a patient's metabolism. I love that, Zach.
We'll certainly lean into more about how we estimate nutritional requirements in various populations a little bit later in the conversation, but maybe big picture before we get there, kind of in the absence of like really specific information on the patient in front of you, what should be a general goal for nutrition in the first week per se of a critical illness? Is there any evidence that can guide us here?
So there is some evidence, and we learn a lot from adult studies, which have actually performed randomized controlled trials. We do not have as many in the pediatric world. I will say that the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition have nutritional guidelines, and they do talk about what a goal for a critically ill child in terms of nutrition should be. They talk about early enteral nutrition. In the research world, that can be defined in many different ways, but here we're talking about the first 48 hours of ICU admission. So they talk about attempting to initiate particularly enteral nutrition in those first 48 hours. And then in terms of goal, in that first week, there is evidence to suggest that achieving about 60% to 2/3 of your nutritional goal, what's being prescribed by a dietitian, estimated to be your requirement in that first week, is associated with better outcomes. This is, to be clear, relevant to enteral nutrition, because the converse is true, which is evidence that supports that we should definitely not be doing parenteral nutrition for most patients on admission and so early on in their ICU admission. In regards to some of the evidence that supports this, the 48-hour mark comes particularly from a very large database study using the VPICU data that showed that starting at least 25% of your goal nutrition in those first 48 hours was associated with a reduction in mortality and less days on the ventilator. And in terms of that first week target, that comes from a large observational study that has included up to 90 PICUs, the Pediatric International Nutrition Study, that showed that achieving 60% of your caloric and protein goal within those first 7 days of ICU admission was associated also with a reduction of mortality.
Nice. When you think about these studies, it's easy for me to hear that and think, well, maybe they were healthier. When you think about these studies, what convinced you that there's a real physiologic association with a reduction in mortality?
That is a great question, Alice. And that is true of any nutritional study. You have to definitely pause and think about how was severity of illness, how were the diagnostic criteria for the different patients being considered, because that definitely influences immensely how we choose to feed someone. And so you're right. If someone is healthier in the ICU or less sick, we might be more inclined to feed you. And so you're automatically less likely to be someone that has a bad outcome. So these studies corrected for severity of illness. And I think that the large size of these studies, the fact that these kinds of findings have been replicated. So I mentioned two of the bigger studies, but they've been replicated in different subcohorts, is what I think supports this data and makes me feel comfortable with achieving this goal in someone who has a functional gastrointestinal tract, very different from the parenteral nutrition data and information. And I do think what's interesting too is that this isn't saying someone needs to reach 100% of their goal at all costs by the end of their first week of ICU admission. It's interesting that this was shown by achieving only about 2/3 of what a patient required, and that you have that full first week. And if you think about the vast majority of ICU patients, by the end of that first week, you tend to be over that big initial phase of resuscitation, multiple pressors. So you should be in a place where you can start trickling in some of this nutrition. And we can talk about the different ways to do it, because for some patients, you might think it's gastric, for others, it's post-pyloric, etc. But if you think about it, by the end of the week, that's not terribly aggressive to give someone a full week to get there.
No, it's very reasonable. So we have our goal of around 2/3 of your goal nutrition by the end of the first week. How are we going to find our goal? We have our ways to estimate. We have ways to measure. Measure might be costly and need specialized equipment. Tell us about how we can estimate the total caloric requirements, and should we believe these estimations in our critically ill patients?
So that is the most common way that we're determining how much a patient requires. It's through these estimates, and the most common equations being used are the Schofield equation, particularly for children older than 2 years of age, and the WHO equation for children younger than 2 years of age. Some dietitians also use the dietitian requirements guidelines. These equations and even some of these estimates, these DRIs, were all developed decades ago. And a lot has changed about our diet, activity rates, things that can influence metabolism and therefore energy requirements. The other factor is that for some of these equations, they were developed in patient populations that may have not been as equally represented or represent the specific patient that you're using it for. So it can lead to inaccurate estimates. There have been studies that have shown this, particularly in the critically ill cohort. They took the energy requirement that was estimated with an equation. They performed indirect calorimetry, which is the measured way of determining energy expenditure. And they found that the equations were off by up to 200%, which is crazy. And the other thing is not just that they can be off by up to 200%, is that it can go in both directions. It could be overestimating for as much as 200%, or it can be underestimating for as much as 200%. And so you don't know where you sit when you estimate this and you start feeding your patient. Am I overestimating? Am I underestimating? The other thing to keep in mind that I hinted at earlier is that we used to think that patients were in this hypermetabolic state. And so I think there was less worry about overestimating requirements. And in fact, we used to add routinely for all patients a stress factor to that equation. But like I mentioned, there's been a lot of advances that have come to show us that in reality, the metabolic rate of many of our patients is not that heightened and for not that very long. And so the risk of overestimating and therefore overfeeding is very high. So what do? Let's not talk about indirect calorimetry yet, because most people, what they have is these equations. What we do is that we start feeding the patient and we see what's happening to their weight. So weights are very important, and it sounds very basic, but I know that many places still struggle with getting weights consistently. The other thing is it is no longer recommended to add stress factors automatically to all patients. In fact, it's discouraged. There might be some patients that should have stress factors added to their energy requirements to how they're estimated. Like I said, the burn population is a cohort that definitely is known to be very hypermetabolic, and so the risk of overfeeding is much lower. But that is no longer recommended. So don't add stress factors, get weights frequently, and then think about indirect calorimetry.
Nice. Now, I have to ask about your opinion on getting weights, because you not only is this your interest in your unit, but you've worked with other units for multi-center trials as well. What's the gold standard for tracking weights of the PICU if we're doing it for nutrition and not for volume status? And then how does that change when maybe a patient's on ECMO, maybe they're intubated, things like that?
That is a great question. And I'll tell you, for as basic as weights should be in our practice, they influence, like you said, not just nutrition, but fluids, medications. I don't think that we talk enough about all these basics. And I think that there's a lot of variability. So I don't want to make a statement where the only way or the best way to do it is this way or that way. What I will say is the best way to get a weight is the way that you'll be able to consistently do it. And so I'll speak to our practice. We are very much comfortable with using weights from zeroed beds. Once you've marked how that bed was zeroed and you consistently use that weight, and we recognize that it might not be that patient's exact weight, but if it's following the trend that you're thinking should be following in the setting of diureses or in the setting of getting adequate nutrition, etc., then it's better than nothing, or waiting to get that perfect standing weight on a scale, right? And so in terms of frequency, weights for assessing response to nutrition from a growth standpoint, and knowing that when you're critically ill, the body is not going to grow as it normally does. It's an adaptive response your body has saying, you know what, I have more important things to do to keep you alive and running than being all tall right now, right, and growing. So knowing that for most patients, particularly patients over the age of 1, a weekly weight is more than adequate. When it comes to nutrition, if you have more active concerns, definitely do it more frequently. And for under the 1 year of age, twice a week, knowing that the younger that patient population is, the faster they're supposed to be growing at that stage. And then as you hinted at, if you're thinking about using your weight for other parameters like fluid, then it could even sometimes be as much as twice a day. If you're, for example, on renal replacement therapies and you're determining how much fluid needs to be taken off and did it work, and that's a whole other podcast on fluids, right? But I do think from that standpoint, weights can sometimes be a little bit more accurate than our eyes and nose, which are hard to capture in sensibles, etc.
No, wise words. And sometimes, in the care of critically ill infants whose ICU stays extend weeks and months, sometimes we do a really good job making their weight higher, but not every time we do a great job making their length longer. So I just want to add on, getting that length to make sure we're getting good somatic growth as well.
Mm-hmm.
And that also reminds me to not forget about our head circumference, which we actually, so if you have an infant in your unit, ideally they're getting weekly lengths and head circumferences. And then you also have your weights. You can also spread them out. I don't know that they have to be weekly. But I think the pace of the unit is a very weird place to say you're going to do something every 2 weeks or once a month. Even if a child is there that long, it gets lost, right? So sometimes it's just easier to say, let's do this once a week and make sure that this child is stable to growing as expected.
Oh, that's great.
Little sprinkles of general pediatrics here, right?
Yeah.
All right. So we've spoken a lot about how to estimate nutritional needs and how to monitor from response from that clinically. But say there's like a high-risk patient that we have in front of us, and perhaps we have access to indirect calorimetry. Tell us more about actually how we measure the nutritional requirements of our patients in the ICU.
So indirect calorimetry it's not the gold standard. The gold standard is direct calorimetry, but we don't have that. So it is the closest to the gold standard that we're going to get to actually have an accurate measure of energy expenditure. And just to remind ourselves, basically, we're trying to measure and capture the work of the body. And so one way to do that is to measure that change in temperature by capturing heat, right? That's direct calorimetry, but we don't have the ability to do that. So instead, what we can do is use 2 very key universal substrates that all of our cells are using to do their job, and that is their oxygen consumption and their carbon dioxide production. And so that's how you end up measuring work in indirect calorimetry. The way to actually do this is by capturing all those gases that that patient is breathing in and out. And in the ICU, in fact, it ends up being a little bit easier because we have a bit of a captive audience. If you're intubated and you have an ET tube that doesn't have a leak, you actually are going to very easily be able to capture those gases and basically sample from the circuit consistently to be able to get that VO2 and VCO2. If a patient is not intubated, you can always use a canopy, and that has been a proven way to measure indirect calorimetry in a non-intubated patient. There are a few things to think about, however, and that is making sure, like I've said, that you're capturing all these gases, so there can't be any leaks. So patients who have chest tubes, you can't do this. If for whatever reason they have a very large leak around that tracheostomy or ET tube, you're not going to get an accurate measure. Patients, unfortunately, on non-invasive and high flow, so non-invasive positive pressure and high flow nasal cannula, are not candidates. We don't have ways of running this even with canopies to ensure that you're capturing all the gases. And I know that the use of non-invasive positive pressure and high flow nasal cannula has grown a fair amount in the pediatric ICU. So the number of patients who are receiving therapy in that way is larger. The other thing that you want is to be able to achieve steady state. And so for the intubated patient, that may be easier. For the non-intubated patient, particularly if they're a toddler and you're trying to get this measurement, it might be a little bit hard to capture them at rest because having a canopy over their head is basically a recipe to have a 2 to 3-year-old not at rest. They're going to be excited about it being there, moving it and lifting it. But if you are intubated and sedated, then you're much more likely to hit that steady state. You're just going to want to keep an eye out for things that change your metabolic demands, such as fever, seizures, chest physiotherapy, suctioning. Suctioning obviously also alters what's being measured in that moment in the gases. And so if you keep an eye out on these things, you should be able to then perform indirect calorimetry in an intubated patient.
Will you tell me more about what's required? So it seems like you need a way to seal off excess gases from either escaping the patient or coming to the patient. You're going to need a way to measure oxygen consumption, a way to measure CO2 exhalation. Any other equipment, or maybe what would this look like if I was watching you measure this at the bedside?
Yeah, so there are machines that measure indirect calorimetry, and you ideally want to use a machine dedicated to do this. So we would bring the machines. Some of them look as large as a ventilator. Some of them actually fit in a kind of like almost suction bag-like look. And we, in fact, did a study where we measured indirect calorimetry in patients who were dependent on tracheostomy and mechanical ventilation in their homes. And it was very portable. The ideal is that you use one of these machines that then have special chips to read the oxygen and the carbon dioxide measurements. You connect the reading port, the sampling port to, let's talk about a mechanically ventilated patient specifically, the sampling port basically to their ET tube, close to the breathing tube side of all the tubing, right? You have the tubing that goes to the ventilator, and you want this to basically be almost where your end tidal monitor would be. And then you actually then just sit and let the machine sample for anywhere from 30 minutes to an hour. And in that time, you will keep an eye out to make sure that at no point the measured VO2 and VCO2 is higher than 10% in variability, because that's what means that you've achieved steady state in this context, is that you're not having more than 10% variability. You don't need to be at steady state the whole 30 minutes to an hour. You just need to be able to capture enough periods of time to steady state to say, okay, this is what this patient's resting metabolic state is. In addition to the machine, then you need staff. You need staff to set it up, staff that's familiar to assess that there's no leak, familiar with the reads and making sure that you're not seeing this variability. And then you need staff to read the output. You then get your output in terms of the VO2, VCO2, particularly set to these steady state periods. And the first thing we tend to do is basically calculated RQ, our respiratory quotient, or VCO2 over our VO2. And that is a bit of a quality parameter. So remembering sort of our biochem classes, right? Our RQ, if you are primarily metabolizing carbohydrate, should be about 1. If you're metabolizing primarily protein, should be about 0.8. And if you're metabolizing primarily fat, should be 0.7. And so your RQ shouldn't be much higher than 1 or much below 0.7. And if it is, you have to question the validity potentially of your indirect calorimetry, because as far as I know, we are not metabolizing other macronutrients. Those are our usual macronutrients. So we use our RQ as a bit of a quality check. And then to actually determine your energy expenditure, those values, that VO2 and VCO2, ends up getting popped into the where equation. And that's what actually then gives you what your estimated energy expenditure is. If I can say one last caveat, I think you heard me specifically say it's ideal that you have a machine that's specific for this. There are ventilators that give estimates for energy expenditure. What's potentially limiting about some of these ventilators is that they are not keeping track of, was the patient having a fever, seizing, was the patient truly in steady state or not. So one has to just take with a grain of salt the energy expenditure output that it gives you. Even though it sounds great to say, oh, I would have a 24-hour measurement, because it doesn't have that person keeping track of periods of time that were truly steady state versus not, one has to be careful with that output from the ventilators. And the other thing is that most of them were created for adults. And so as you become a younger and younger child and your minute ventilation is much higher because you're an infant, you can bump into more errors in measurement because you need machinery that is that much more fine-tuned for that amount of small changes in gas exchange that a patient who is of infant age is having, right? Because they tend to breathe faster. And their total tidal volumes per weight, they might be the same as an adult, but their total tidal volumes are smaller. And so that is the one caution I want to say about ventilators that read energy expenditure.
It sounds like this is really important science and information for people to be doing, but it also sounds like maybe there are a lot of research pitfalls here, right? Like if a fellow joins us at Cohen's and they're like, I need to do nutrition research, it sounds like many, many ways we could get it wrong, including like, oh, look at this page on the servo. What about that, right? And you're just kind of fighting those off.
Well, that could be true, but also that's the fun part of research and learning, is that you become familiar with those pitfalls and keeping an eye out on them, and then you can overcome them and, then sit at the ventilator and find that steady state spot and say, okay, well, this is the measurement that I do trust because the others had too much variability. So it's totally doable. I just wanted us to be aware that sometimes just because a machine gives us a number, it doesn't always mean that it can be trusted. You want to think about that it meet all the marks for giving us the best result.
This is excellent. I was incorrect in thinking that we're going to have to put this patient like in a 24-hour capsule, so to speak, to like measure.
I was thinking 24 hours too.
Yes.
Yeah, that's what I always pictured.
But it seems like you're just trying to figure out when this child is completely at rest, what is their resting energy expenditure? And like perhaps you can get that information out of an hour. And then maybe if they were being suctioned or they're acutely agitated for a moment there, you can maybe not take that data into consideration, but see when they're at rest and you feel like they're at that best steady state and use that to estimate their 24-hour requirements. Does that sound right?
That is spot on, Zach. Yeah. One thing to say, and there have been at least a few case reports on this, is that routinely we think about indirect calorimetry and estimating energy expenditure as what you need at your basal metabolic rate, right? Most of us are not Olympic athletes who need 10 times as many calories, right? Their resting metabolic rate is different. So we're thinking about just the average ICU patient who's intubated, sedated, etc. But you bring up an excellent point, which is that for some patients, if they don't appear to be gaining weight the way you thought they were supposed to, etc., it's possible that what's happening when they're not at rest is accounting for a lot more of their energy expenditure that we are appreciating. And so, although this is not the usual use for indirect calorimetry, sometimes you do need to have prolonged IC tests, maybe even 24 hours, or ICs that run purposefully during a patient's stress period. And one example that has been reported is in patients who maybe they had traumatic brain injury and now they're having autonomic storming. And if you do your resting energy expenditure, you're capturing that patient at rest when they're not storming, and you assume that's what they need for 24 hours. But if they're storming and during that period their metabolic demand is quadrupling, you need to account for that. And so there are some patients when you're going to want to actually perform IC kind of purposefully outside of the resting period. You just want to be aware of why you're doing it. And you may even want to do 24 hours. I think that's the nutritionist's dream, but you don't have to. And there are even some studies out there that say that as little as 3 to 4 minutes of steady state measurement could be extrapolated to what someone needs in 24 hours, assuming they're not having any of these vacillating periods of sudden hypermetabolism.
So obviously, this is only done at larger centers, perhaps with the educational and research focus that comes along with it. I'm curious to know, in your practice, perhaps how often do you use this, and what particular patient populations would you be most likely to use it?
So I'll start with the patient population. We follow the ASPEN, the American Society for Parenteral and Enteral Nutrition guidelines, and they suggest using IC in patients who are at the extremes of weight, so patients who are very undernourished or obese, patients who've had significant changes in their weight while under our care. That could mean 10% about of a weight change. Anybody who's been mechanically ventilated and or paralyzed for a long time, and that means about a week. Prolonged ICU stay, so patients who are with us for more than 2 to 4 weeks. And then patients who are at risk of altered metabolism. And I gave you an example, patients with autonomic storming. Oncology patients tend to have quite altered metabolism. The converse could be a neuro injury that doesn't have autonomic storming, could be hypometabolic. And so these are all patients that would be candidates. What you may be appreciating from that is that that can account for a large number of patients in the PICU. And in fact, there was a group out of Texas Children's who estimated that at any given point, about 2/3 of patients in the PICU meet at least one of these criteria. And so many patients could benefit from indirect calorimetry. I am not sure exactly how many ICs we do. The gastroenterology nutrition group run it. And so I don't always find out when somebody requested it.
Interesting. So this could be just you're rounding, you have your typical team, handful of intubated kids, handful of non-intubated kids. And then one day you see like a note when you're pre-rounding and it's like nutrition came in, we did indirect calorimetry, like that type of thing. Like it just happens.
Yes and no. So we have a dedicated group of dietitians in our ICU, which is wonderful. And they help us immensely with everything from estimating those energy requirements, keeping track of whether the patient is moving on track with the weight gain that we were hoping they would have. And they are the ones often who will bring up, I am worried about this patient. We should consider indirect calorimetry. And they do let the primary team know. The primary team is always more than happy to facilitate it and support it. And then they basically consult the gastroenterology and nutrition team that performs IC. So the primary team would be aware, but it's not uncommon that it is our awesome dietitians who are bringing up concerns about someone's weight gain and saying this would be a good patient for indirect calorimetry because I've looked at the equations back and forth and clearly we just need to measure and see where they're at.
I think that makes the most sense to have the nutrition team being the one advocating for these, because as the ICU physician coming on for a week of service, I don't know what this child's weight necessarily or looked like when they came into the hospital, perhaps even months ago. And, gosh, I'm worried about the ABCs, and sometimes nutrition is way down there. And I would imagine having this separate team advocate just helps getting this put into place and getting the benefits of this knowledge.
Yes, and they're looking at the growth curves. We are pulling up our heart rate trends and our blood pressure trends, and they're pulling up not just the weight, but the actual full growth curve. And sometimes are talking to the parents directly and confirming that the child was in fact growing on X percentile. And so, yes, we're comfortable where they're at, or no, they were worried about the child's growth before they arrived. And so I think this is a good plug for the fact that anything that you do nutrition, including indirect calorimetry, benefits immensely from having kind of a nutrition team. And the composition of that team varies from hospital to hospital. Ours is primarily the dietitians and then Some physicians and nurse practitioners and pharmacists with an interest in nutrition work closely with them, but they're kind of our frontline provider that is really helping us ensure we're doing the best that we can do for all of our patients. But other hospitals have slightly different structures that are maybe more physician focused or nursing driven. And so I think just deciding who's going to be that person who's going to keep the bigger picture is good. And these nutrition teams actually have been shown to improve outcome in pediatric critical illness and adult critical illness.
Oh, well, I definitely believe it and I'm very grateful for ours. Zach, do you guys do indirect calorimetry at UT Southwestern?
No, I think there's been some interest in the past, but we don't do it.
Yeah, I've never worked somewhere where they did it either. So it's so interesting to me that it's possible and in the recommendations.
It is, yeah. One thing that's interesting is that for sure in the adult world, there have been studies that have looked at whether there is a change in outcome when you implement indirect calorimetry for all comers and to determine energy expenditure for everybody, and it did not have an effect. Okay. And so I do think it's one of those therapies that it's more about truly personalized care and maybe more targeted, as opposed to thinking that everybody has to have indirect calorimetry and that everybody is going to benefit from it equally. I didn't even mention the fact that in the ICU, there's a group of patients who maybe meet criteria for indirect calorimetry because of the duration of their mechanical ventilation or paralysis, but they're actually not good candidates, not just because of air leak, like I mentioned, but also your supplemental oxygen cannot be ideally above 60%, your FiO2. And, some of those chronically mechanically ventilated paralyzed patients are the ones who are struggling and are on a really high FiO2. And also certain special circumstances that alter gas exchange or CO2 metabolism, like ECMO and CRRT. So sometimes the patient where you most want it is the patient where we least know exactly how to implement it. I know that there are huge efforts in understanding how to use indirect calorimetry in the ECMO population. It is a population that would benefit from it immensely, particularly someone who's on ECMO on a bridge to lung transplant, and you're trying to rehab and you're trying to understand their nutritional needs. And yet it's not yet fully understood how to do it. And so it's not widely available.
Oh, thank you. Now, while we're talking about this, we've got our standard measurements. We've got indirect calorimetry. When we were studying for the boards, we discovered a world of serum biomarkers of nutrition that we memorized real quick. Are any of those used in practice? What should we know about these?
They're not routinely used. I don't think we all use them. I think they become important for the chronically critically ill patient that ends up being in the ICU for a fair amount of time, and you're trying to use as many parameters as you can to understand where they're at. As you may have learned, the problem with many of these serum markers is that they are significantly altered by the inflammatory state of a critically ill patient. And that is also true of micronutrients. And so there have been studies thinking, well, maybe if someone's vitamin, X is optimized, they're going to have better outcomes. And the problem is that we don't even know how to categorize patients as being deficient in critical illness, because many of these vitamins and micronutrients are protein bound. And in the setting of being critically ill and having capillary leak, you end up actually having significant shifts in your proteins, and your body's also shuttling protein in other places. And so these markers can definitely be considered to trend, particularly if somebody is chronically critically ill, but they're a little bit harder to interpret in acute illness. And they're definitely harder to interpret in critical illness compared to the non-critically ill population, where these markers are much more routinely used.
This has been excellent, talking about the estimates of nutritional requirements. The cynic listening might be saying, this child that you're feeding is not growing. You obviously just need to feed them more. Why are you worried about measuring, et cetera, et cetera? With that, what are the harms of overfeeding kids that are critically ill in ICU?
So one of the biggest concerns is that when you overfeed someone, the primary macronutrient that you tend to be increasing is your carbohydrate load. And that needs to get converted into CO2. And so you're actually potentially increasing someone's respiratory failure. You're making it worse. You're increasing their need to have a higher minute ventilation, et cetera. So that's one concern. The other one is that if the body is just not metabolizing things appropriately, it can be converting some of these extra carbohydrate into triglycerides and fat. And when you're thinking about rehab and you're thinking about recovery, you're not thinking about accruing fat, right? Giving more calories, hoping the patient will grow without addressing, like we talked at the beginning, the trigger, understanding sort of like their metabolic state, unfortunately doesn't actually result in the patient growing the way that you want them to, but can result in this fat accrual and also increasing their respiratory work.